This episode of Pupil Pod is supported by Dompe.
Welcome to Pupil Pod, where we use clinical cases to guide discussions on board review topics. I'm your host, Sila Bal, and my guest today is Dr. Ike Ahmed. Dr. Ahmed is joining us today for part 2 of our series on glaucoma treatment, so if you haven't already, definitely check out part 1 where we discuss glaucoma surgery in more detail. Dr. Ahmed, thank you again for joining me today.
Sila, good to be back here. Looking forward to the next case here.
So this is a case of a 57-year-old man with pseudoexfoliation glaucoma who presents to your office for a second opinion. On presentation, his IOP is 25 in the right eye and 24 in the left eye. He heard that doctors are treating glaucoma with lasers instead of eye drops and would like to hear more about these therapies. Dr. Ahmed, which types of glaucoma are most appropriate for laser trabeculoplasty?
Well, Sila, this is a really hot topic these days because, especially with the publication of the SLT Light study, which is a well-funded, well-designed study. I mean, the evidence that's leaning toward using laser trabeculoplasty, specifically SLT in that study as first line, has really come to fore. And so many of us have always been thinking about it first line. I think now the day has come where the benefits outweigh the risks and the benefits of long-term control and compliance are clear. Now, there are typical glaucomas that we think about laser trabeculoplasty, and those, of course, include primary open glaucoma. Pigmentary glaucoma has a reasonable response. And pseudoexfoliation actually also responds fairly well, although sometimes the duration may be a little less long. We've also had good experience in steroid glaucoma. For example, patients who've had intravitreal Kenalog, and that can often buy us some time in those cases as well. So really, those are probably some of the more classical indications. Now, there are certain indications where trabeculoplasty would not be a good choice for, and that would include patients who have, of course, angle closure, synechial closure, PAS in the eye as well. Patients who have a uveitic glaucoma that maybe is active. Although I will say for patients who have who are quiet, and maybe have a steroid response, it's worth trying. Neovascular glaucoma, proliferative conditions like ice syndrome would also be a contraindication, and anything that's causing a pretrabecular mesenteric obstruction. Developmental and juvenile glaucoma is a little bit controversial. Classically, we would say that the response isn't as good, although I think considering the safety of trabeculoplasty, it often is a consideration to treat. And one last thing, maybe we'll talk about it during complications. With pigment glaucoma, we've got to be a little bit careful not to do too heavy a treatment because that patient may be at risk for IOP spikes.
And how much IOP lowering can we expect in patients undergoing a trabeculoplasty?
So, some of the work done on primary therapy have shown up to a 30% drop in pressure. Now, if you're using it more as second, third, or fourth line even, then, of course, patients are on drops already likely, and the pressures may be a little lower than in primary purposes. And in those cases, we typically expect a 20-25% reduction. I should also add that not everyone responds to trabeculoplasty. And so, often we see a response rate from 70 to 80%, especially when it's not used first line.
This is going to sound like a silly question, but really, how does trabeculoplasty work?
It's not a silly question. In fact, my answer is going to be even more basic because we don't know the answer really. But some of the mechanisms that we consider, especially back from the ALT work and SLT work, initially, of course, the first thought was we're poking holes in the TM, and that's causing openings to basically allow liquid to drain. Well, that's not what happens, of course. In ALT, certainly, which typically is using either photocoagulation historically with argon and nowadays using a 532 typically. This results in some thermal trauma to the TM and causes a contraction of the TM beams, and therefore we have stretch and widening of the spaces in between those laser applications, and this is felt to perhaps increase outflow. However, now that we see more work with SLT and even micropulsing, we see that this is probably more of a chemical or biological or an inflammatory, low-grade inflammatory mechanism that may be also present for ALT. And SLT uses a Q-switched frequency doubled YAG laser. This is selectively targeted toward pigment in the melanosomes of the trabecular meshwork. And this results in a subtle stimulation of cytokines. And this stimulates macrophages to basically start be activating and gobble up some of the extracellular matrix, which reduces the resistance in the trabecular meshwork. It also may cause some turnover in a biological fashion to the trabecular cells. And so that's the inflammatory mechanism, the biological mechanism that we typically see. So I think there's probably a combination of a few, but with SLT, we don't typically see that kind of contraction and physical changes. And I think the chemical and the biological effects are likely more of an impact, which are essentially mediated through MMPs, matrix metalloproteinases.
It's so incredible in ophthalmology what we can do with lasers and how our body responds to those lasers. What are some of the complications of trabeculoplasty?
Fortunately, they're not common, but some of the early ones we think about, of course, are like IOP spikes and inflammation. Spikes happen more commonly, as I mentioned earlier, with people with more pigment. So I recommend doing a shorter treatment. I should mention actually that, people do go back and forth between 180 degrees versus 360. I'm more of a 360-degree treatment with SLT. That's my go-to. Although people with more pigment, I typically reserve more of a 180-degree treatment with lower energy and less shots. But IOP spikes can happen, up to 20% in patients with open-angle glaucoma. Inflammation is usually, limited. And we don't typically even treat patients with steroids. In fact, some people argue, and some evidence states that steroids themselves may reduce the effectiveness of laser trabeculoplasty, considering the mechanism itself may be inflammatory. So we typically use non-steroidals or no medications in that. And then I think, the other thing we think about long-term is sometimes we get a bit of PAS formation that can form where the applications were made. Less so with some of the newer trabeculoplasty techniques, but that's something we sometimes see long-term post-operatively. So fortunately, it's pretty rare. And because of the IOP spike issue, there are certain patients we like to check their pressure at 1 hour. And those are patients with more advanced disease, patients with more medicated, and patients with more pigment are higher risk of IOP spikes. And so we check them back at an hour. And if we need to, we add medications. We typically prophylax with alpha agonists, I should say, before treating. That helps to blunt those IOP spikes.
And at what point do you expect to see results?
So yeah, it's a good question. I mean, sometimes we see the results quite soon, but considering the mechanism of action, it can take up to 4 to 6 weeks, and rarely can take sometimes 3 months. So I typically don't write off a trabeculoplasty until we've waited 3 months. Now, the response rate for trabeculoplasty isn't necessarily 100%. Primary treatment, again, like I said, is a higher response rate, but you can expect most patients, 80+% of patients, will respond with some pressure drop. And this typically will last more than a year, up to 2 years. But the success rate does drop sequentially over the period of time in follow-up. If you're doing primary therapy, you can expect 3/4 of patients will be successful at 3 years, while secondary or tertiary treatments can basically be about 50% at 3 to 5 years.
Great. So, since we're on the topic of lasers, could you tell us a little bit more about when you would consider using cyclodestruction?
Yeah, I mean, this is kind of evolving. We typically reserve these in patients who are not good surgical candidates. Maybe they've had multiple previous surgeries and they don't do well with con surgery. Patients who can't go to the OR, because of other medical reasons, and patients who have pain and have a painful blind eye with high pressures. And so those are typically the ones that we look to. There are folks that are using it earlier, and I should differentiate, for example, transscleral from endoscopic. Maybe we'll talk about that. But in general, the classical transscleral applications are what I mentioned earlier as far as indications.
Yeah, so that was actually my next question is what are the types of cyclodestruction that we still use in practice today?
So I would divide them up in 3 ways. One is the classical transscleral, where basically we're using continuous wave laser, typically 810 nanometer laser, diode laser, to literally heat and destroy the cellular body tissue. That's the classical scenario we spoke about earlier in those indications, and that's typically a later term procedure we use, and maybe that eyes are not seeing well and have poor surgical outcomes otherwise. We've seen the innovation of micropulse laser, and that basically applies laser in small packages which are less thermal destructive. Some have used them earlier for that reason. I think we're still evolving in where that fits, but certainly they seem to be a safer use of cycloablation procedures. But we're still evolving where it fits. And then the third category is endoscopic cyclophotocoagulation, which has commonly been used with cataract surgery because of the direct and titratable treatment of the ciliary processes, the response is not typically as strong, but the risks aren't as great either. And now we see people often combining ECP or endoscopic cyclophotocoagulation with MIGS as well. So I will say that cycloablation is still kind of all over the place. There's a classical indication, but now with micropulse and endoscopic laser, people are using them earlier and often even combined with cataract surgery. But it is certainly treating glaucoma in a very different way than our surgical procedures.
Yeah, it's incredible. Going through these outlines, I don't think I realized how many different types of glaucoma treatment there are and how many different combinations of those subtypes there are. But going back to the cyclodestruction, what are some of the complications that you see in these patients?
I mean, the biggest thing we worry about, of course, is hypotony. That's what you read about. That's what you hear about, of course, with the old cyclocryotherapies. But these are much less common now with the diode lasers that we use, even the transscleral techniques that we use with the continuous wave energy. But these are eyes typically that are higher risk for it, diabetic eyes and eyes that have had multiple surgeries and maybe juvenile cases that you may sometimes see hypotony, and for that reason we want to be careful and titrate. Inflammation and uveitis and CME are something we do see with all kinds of endoscopic treatment. We are treating uveal tissue, so treating the inflammation is important, and preventing CME with nonsteroidals are helpful and important in those eyes as well. And ultimately, we worry about things like ptysis if the hypotony is persistent, and that's what we really, really worry about. Rarely do we see hemorrhages and retinal detachments, and of course, there's pain. I mean, the procedure can be painful, and we typically treat patients with that. Probably some of the most devastating things we've seen in the literature has been some things like sympathetic ophthalmia, which is, of course, the fellow eye developing a sympathetic response to cyclotherapy, and that's typically what we saw with cryotherapy. With diode laser, it's not something that I really am concerned about, but that's a more of historical context. So, yeah, it's a big gun and it's a bit hard to titrate, but there's a place, I think, when we see this in the cases we discussed earlier.
And on to our final glaucoma laser, iridotomy. So, normally we think of iridotomies as a treatment for pupillary block causing angle closure, but they're also used for things like diagnosing plateau iris syndrome. So, Dr. Ahmed, what are some cases of angle closure when you would actually not prefer to use an iridotomy?
That's a good question, and something actually I always push to my fellows, because we often say, yeah, do a PI. The patient's got angle closure. Do a PI. Their pressures are up and they've got grade 0 angles. But there are situations that I'm particularly careful when, number one, we have a large amount of PAS, because the angle is not going to open up, and we may overload the eye with inflammation and pigment if there is a small area of the opening that does open up. So, eyes with more than 180 degrees PAS, I'm careful. Certainly, if they have 360 degrees PAS, I would not, and that's typically a surgical consideration. Going to CK lysis if phaco if necessary. Angle closure from other mechanisms other than primary, pupil block or the sort, I'd be careful of. Things like, for example, neovascular glaucoma, eye syndrome, even uveitic, PAS, I'd be careful and would avoid that. Although, of course, in uveitis, sometimes we do PIs to prevent the posterior synechia from causing pupil block. But be careful if you have a lot of synechia in the angle in those cases. Of course, if they have an opacified cornea, there's no view. Eyes that have a flat AC where you cannot get any space to do the laser will be a contraindication. And I'm always careful for patients who've had a long history of open angle glaucoma and they present with angle closure or a grade 0 angle, because that patient probably has a combined mechanism. And even if you do a PI and open the angle, the PI, the laser itself with inflammation, may provoke the open angle from causing an IOP spike. So I'm careful in those cases if they have a combined mechanism possibility.
Thank you. That was a very comprehensive overview of the lasers that we use in glaucoma and the treatment of glaucoma using lasers. So, just to summarize, laser trabeculoplasty can achieve a 20 to 25% reduction of IOP in cases of mild to moderate primary open angle glaucoma, pigmentary glaucoma, pseudoexfoliation, and steroid induced glaucomas. The IOP lowering effect is thought to be due to chemical mediators like we discussed, such as IL-1 and TNF alpha. This release of chemical mediators is thought to increase flow through the trabecular meshwork, which is really an incredible mechanism for how these lasers work. In eyes with poor vision and refractory or painful glaucoma, cyclodestruction can be used. And as Dr. Ahmed taught us, sometimes we're even using it earlier and earlier. However, complications to be mindful of in these cases include hypotony and phthisis. Iridotomies can be used to treat both angle closure from pupillary block and to diagnose plateau iris syndrome, though we need to keep the contraindications in mind. So, Dr. Ahmed, before we end the episode, I ask all of my guests, if you could have dinner with one person from any time or place in the history of humanity, who would it be?
I want to congratulate you for being a great interview and putting this together. And I think this is going to be such a great resource for those in training and likewise as well those that are in practice. So it's a good question. I mean, I love hanging with people. I'll be honest with you, but the person I probably would be most interested would be Muhammad Ali. And the reason why I would pick Muhammad Ali is because I truly admire that man's courage. You know, in a time when, you know, it was easy to fold up or easy to fall in line. I mean, he stood on principle. I mean, when it wasn't popular, he was in the prime of his life. He was, you know, on the verge of continuing to be a great champion. And he basically sat out for so many years because he stood for principle against the war. And the courage to do that when the whole world was against you and your government was against you and you were, you know, threatened to go to jail and stripped of your titles and the racist things that were happening at the time. I mean, to stand up and have that strength of being alone, like that is admirable, you know. And then to come back and to develop such a admiration amongst the world of all walks of life, you know, white, black, brown, doesn't matter. I mean, around the world, and have that following because of his conviction, you know, and his charisma. I mean, like he just for me just embodies a true humanitarian and someone to aspire and be inspired. So, yeah, I would say it would be Muhammad Ali, and I'm sure it would be an enlightening conversation.
Yeah, that's a beautiful answer. I think we could all aspire to leave that mark of our uniqueness on this world. So the fact that he was able to be a leader and be so unique and such a great individual, I think is what is most inspiring. Dr. Ahmed, thank you so much for your answer. Thank you for joining us today. It was really so much fun to record these episodes.
Hey, thanks for being here. I'm looking forward to People Pod, and the music was fantastic. I'm never going to forget.
And thank you to our listeners. See you next time on the Pupil Pod.